Hi, good day, everyone. My name is Solange Baptiste, and I'm the Executive Director at the International Treatment Preparedness Coalition, or ITPC. And I wanted to thank the organizers for the opportunity to have this session today. My topic is prioritizing the role of community-based healthcare delivery in the context of COVID-19. So I wanted to start off with just a very simple definition about what we're talking about. So we're talking about community-based healthcare delivery, and what does that actually mean? It means delivering healthcare outside of the clinic, in a very simple sense. So when we think about that, we can think about what does that mean in terms of who. So who is actually delivering the care outside of the clinic? And we can think about community healthcare practitioners as a whole, comprised of many healthcare providers, including healthcare workers that are in the field, like doctors, field nurses, outreach healthcare workers. There are different terms in different parts of the world, as well as community healthcare workers, and however those could be defined as lay providers who have been upskilled in their ability to deliver healthcare. And we can have some sort of images and pictures in our minds about what that kind of delivery can look like in those last pictures that I put up. We could also think about what is being delivered during this community-based healthcare. And that could range, and in the context of HIV in particular, we can think about home-based care, we think about adherence and psychosocial support clubs. As you can see in that picture there, and these pictures have been borrowed and the credits are below. We're looking at also groups, and these are obviously pre-COVID because no one there is wearing a mask or socially distanced, but you get the idea of what kinds of things we're talking about, where multi-month refills are being handed out by maybe the lead in that group that goes and they rotate, and then drop-in centers are another example. Of course, these are not exhaustive lists, but these are just examples of what a sense, a flavor of what community-based healthcare can look like. And then we can apply these to not just HIV, and also wanted to put in there advanced HIV disease, or it could just be normal and call it AIDS. We could also apply it to TB, sexual and reproductive health, even primary healthcare, and non-communicable diseases. And I think we need to start to think about that, especially in the context of COVID and the pressure on all of our resources. So why community-based healthcare delivery is important? People often cannot afford to access what is supposed to be free in the official health system, the public health system, because we know that there are other costs related to accessing healthcare, including transportation, time from work, a few common examples. We also know that broad public health messaging does not always connect with communities, especially with key and vulnerable populations. And we also can think about it in the context of COVID, where we were telling people as broad public health messages, if you're at risk, stay at home, and what are you at risk for? And they would say, pre-existing conditions such as, diabetes or hypertension. And many communities, when you translate that, is kind of like one in 1 year, out the other. And you really need to be able to speak in a language that connects with people for them to actually carry out the changed good public health behavior that you're seeking. And then there are also issues of, as we know, about trust in the formal public health care system, especially for quality care. That trust is very low, and it's something that's, if it is okay, it is still a bit fragile. So why now? Why is community-based healthcare delivery important now? So we know that the context of the world that we're living in has changed drastically since, let's say, February or January this year. The urgency of COVID caused us we need to reduce transmission because it's a highly transmissible disease. And we recommend that people do not go to clinics unless they are absolutely really, really very sick. And so they're now this puts the emphasis on non-clinic based healthcare, which means community-based healthcare. And people are also afraid to attend public health facilities as they think that they could contract COVID-19. So one of the questions that we have been getting as ITPC, which from different stakeholders, is what's happening on the ground? What are the areas? What are you hearing? What's happening? And so I'm going to give a few snapshots of some of the things we're hearing globally, not just in the continent of Africa. as listed as sources here from our Global Activist Network. We had done recently, it's not yet published, but will be soon, a rapid assessment in Kathmandu, Nepal, in partnership with Justi Nepal and UNAIDS, and also in ITPC South Asia. So due to lockdown restrictions on travel, accessing the following is very difficult. So people have difficulty accessing HIV testing, viral load testing, even getting their ARVs at the clinic is a problem, accessing second and third line medicines, accessing ARVs when outside of your catchment area. So, you know, lockdowns came, there was no real great warning, and people are sometimes outside of their current village. They were somewhere else for work where they usually had signed up for their medicines. It's not where they naturally, like, their physical address is. And so they have difficulties in accessing the ARVs. Communities have been innovating in terms of adherence, sort of interventions at the community level to be able to make sure that people have their medicines delivered to them. And this is particularly acute for second and third line medicines. There's also fear of COVID-19 exposure at the clinic, and that was echoed in the previous slide. Free viral load tests now offered for a fee for those who would like to switch or need to switch from, let's say, efavirenz-based regimens to dolutegravir-based regimens, which is the current recommendation. I just put also here an excerpt from our rapid assessment. This is one lady who was talking about her difficulty in accessing her medicines and ARTs. During lockdown, there was a restriction in transportation mobility, so I went by walking to have my ART medicines. It took about 6 hours of walk to get to the ART clinic and then return home. So people are really going through them drastic and dire situations to be able to access their medicines. We also know that some healthcare workers also fear their patients transmitting COVID-19 to them. So really the misinformation and disinformation sometimes that is spread, and the importance of effective communication, public health messaging, not only for people living with HIV and quote unquote patients or recipients of care, but also for healthcare workers in this rapidly changing environment where you would have learned one thing last month about one particular therapeutic for COVID-19, or some new study has come out and it has changed the very next month. So we really need to keep pace with that and make sure the information is coming out. Stigma and fear of disclosure on HIV status, as you can imagine, sheltering in place is not, there are unintended consequences of saying stay at home and prevent the spread of COVID-19, because not everyone has disclosed their HIV status, and so they would prefer not to get their ARVs delivered at home. So they're really nuanced things, and it plays out differently in different contexts, different countries across the globe. We also think about we've heard about integrated care and that not being available. The quote below says, the center where I'm taking ART doesn't give other health services. If any other conditions or disease occur, I need to visit other hospitals. So this is also costly because of transportation, but also those other tests or opportunistic infections or other screenings also cost money. So we need to do better there. And there's obviously this real issue of not only a global economic recession, but each country, and obviously those most vulnerable are even more vulnerable now in terms of income and food instability. This is another excerpt from our work in Kathmandu. I keep searching for work. Some days I find work, some days I don't. I hardly manage for food. There are days when I don't eat and feed my children due to lack of food. There's always a lack of food in my house. I need to feed my children even while I eat only enough to fill half my stomach. We eat when I get work, otherwise we don't eat. And this is the last slide, just talking about what is happening on the ground. In some countries, some services have completely stopped, and examples are listed here, like voluntary male circumcision, which is a major prevention intervention, new initiatives of, new initiation, of pre-exposure prophylaxis, and TPT are also have completely stopped in some countries, condom distribution to walk-in clients, routine scheduled viral load monitoring for clinically stable adult persons living with HIV, teen clubs and other patient support groups that involved gathering of people have stopped, and active tracing involving community visits. These things obviously have changed over time because countries have lifted their their restrictions, and some have had to revert to stronger lockdown restrictions, and these things are invariably affected. But it's important to see how there are trade-offs in this current COVID-19 context in terms of services that are being delivered or should be available at the clinic level, and how could these things be translated in terms of community-based delivery. And I thought it was good to put here the top needs that we've heard from people living with HIV. I won't go into too much detail, but food, medicines, nutrition. Before people get their medicines, they need to eat. If someone is starving, they're not going to be too concerned about going to spend money to drive to get to their ARVs, but they're looking for food. So if we need to address that need. Medicine uninterrupted treatment, because when you are in a relatively stable situation, you want to also feel well, you want to be able to get your medicines, and transport to and from facilities is very difficult. And we think about other drop-off methods, sort of the community-based health delivery system, bike riders, sort of Uber for these community adherence groups and for ARVs. There's a need for an economic safety net. None of these things are easy to be fixed. An accurate, widespread, low literacy COVID-19 information. One person put it, they said every cough and sneeze, cold and fever is attributed to COVID-19 now, and it's not very clear in terms of the prevention and sort of triage messaging. And there's also legal aid that is necessary due to increased gender-based violence as more people stay home and have to shelter in place as families or extended families, especially for sex workers. This was raised as an important need. And then the kind of obvious one, but you may not think that it is, it may not cross your mind, but it's not always free, and it is not always cheap to be able to have personal protective equipment, access to clean water and soap and hand sanitizers or sanitizers. So this topic that I was asked to speak about was not just about community-based healthcare delivery, but about prioritizing it. And what does that mean? And I thought that this cartoon would be interesting. It says, you're right, it is easier said than done. That's why it is, I said it, because it's easy. So just try and keep up. There's a lot of talk about community-based healthcare delivery, but not necessarily much action. And we certainly have an unequal action taking place across countries, and also within countries as a subnational level. There are different levels of effort. I thought I would ask this question because in 2016, the United Nations Political Declaration on Ending AIDS by member states set the world on this fast track, right, to end the epidemic by 2030. So I just, maybe everybody listening to me at this point know the answer to this question, but some of you may not. What percentage of service delivery did member states agree to that should be community-led? And the answer to that is 30%. You can read this as in point 19, the reference is below on the UNAIDS website, but it says that we would ensure that at least 30% of service delivery by 2030 is community-led. And I guess this begs the question, what is our current level? And we can have a whole other session on data and how it is collected and what is actually community-led and what is not, and how this data is quite blurry and fuzzy. And I do not think we are anywhere near close to 30% of the investments. So again, thinking about community-based healthcare delivery, in order to prioritize it, we must do a few things. And this list, again, is not exhaustive, but a few important ones that I want to raise. We must actually resource this investment. We must actually, invest in skills. We must invest in the correct information and literacy and health education that goes around it. Personal protective equipment so that it can be done properly in the context of COVID-19, human resources, the staffing, and as well as, yes, we need money. We need to be able to enact policies and regulations that enable these resources that are inputs in the first bullet to actually work. So if we think about progressive task shifting, different countries have very different regulations. You have to have a white lab coat and have gone to pharmacy school in order to hand out some medicine to someone. And there's a very sort of nuanced rollout and implementation between dispensaries and pharmacies. And we need to think about this in a more progressive way, because people show up as a whole person. So why can I not get my medicine for my diabetes and hypertension, as well as my ARVs, all at the same time and for multiple months? So this is another question about integration, which we've paid a lot of lip service to in the past, and we really need to see how we can do this going forward, because single disease focus is not going to get us very far. And if we're serious, we also need to make sure that we measure success by metrics that are defined by all stakeholders, to not have an unduly biomedical, quantitative kind of view, but also understand metrics from a community perspective, the recipients of care perspective, and usually the qualitative and the quality targets of the kind that is it rude service, is the service acceptable. Those quality targets are hardly ever really set and measured very well. So we need to make sure that we do that. And then this last point is really to just say that we need to make sure that the HIV response balances the responsibility to provide the public health care that you're supposed to as a government, because it's the right to health, but also invest in supportive self-management. So don't abdicate the responsibility to provide it and say, yeah, okay, it's tough, so the community will do that, but really be able to balance both. Sadly, I have to say this, but all of this can be easily undermined by stigma if it is not addressed. And this has been seen in every single survey, and even more so now, where there's sort of a conflating of stigma. So there's stigma for HIV, there's a stigma for TB, and then there's a stigma for COVID-19, and all the symptoms between TB and COVID-19 are quite similar. So there's a whole confusion about that. And so stigma is something that really needs to be addressed if we are to do this well. Community-based healthcare is necessary, but not sufficient. And we need to prioritize community-based healthcare, yes, but we also need to ensure that there's investment and scaling of community-led interventions. And that's not what this topic is, but I thought we needed to pivot there as I wrap up. Community-based makes us focus upon where we're doing it, which is how I started off by the definition. So it's not in the clinic, it's not in the hospital, it's not in the traditional setting, but it is really now in the community. And that's good and important. But we also need to think about who is delivering the service, which goes back to my third slide. Who is delivering the service? And we need to have an investment and scale up of community-led initiatives. So not only the healthcare delivery, but also monitoring, research, and advocacy. These things are critical. I just wanted to talk a bit about then the community data. So HIV responses, as we know, are still hindered by gaps in the availability of certain types of data. So we can, we have issues with size estimates, particularly for key populations. We don't have good data on that is disaggregated by gender and age. Data on policy and legal barriers to accessing services, and also the why to what we see and why those things still persist, those issues still persist. So community data is a valuable piece of the whole data story for the HIV global response. And this is something that has to be led by communities, right? Community data is generated by communities. It's not data that is taken from the community as a sort of a crucible in which you do your experiments. And the sources of this would include things like research, surveys, and monitoring. I'll talk a little bit about ITPC's monitoring and advocacy, and then I'll wrap up. So community-led monitoring is not the monitoring of people, but instead it is really the monitoring of services by communities. The monitoring is routine. Indicators are predominantly those that are relevant to communities, and it makes sure that we have we provide a platform for the missing voice in the response to make sure that we can advocate for the necessary change. This is an example of our work that was done in West Africa, funded by the Global Fund in 11 countries. We had done 2 years of monitoring done by people living with HIV networks, the national networks in 11 countries in West Africa. You can see the size of the data set, and the next slide here shows a real quick snapshot of some of the more pertinent successes that we've had. In the monitored facilities across these 11 countries, we looked at in the first row, red, purple, and blue, things that should be decreasing across those periods due to the intervention of monitoring and the advocacy. We're able to reduce ART stockouts via lab supply stockout and the length in days of ART stockouts. And conversely, figures 4, 5, and 6 in the brown, navy blue, and sort of mossy green, we have the bar charts going up. Everything that we want to increase did increase: the quality of care, viral load tests performed, and the viral load suppression in the monitored sites across those periods. So really concrete data that can be generated by communities and used for change. Because obviously all of this is good, lots of talk, but there is no change if not. So here we have a snapshot of regional advocacy priorities organized by the 390s. I will not go into too much detail here, but really seeing how these things fit and the advocacy priorities set by the advisory board at a regional level really was able to speak to the work that needed to be done. And here's one country example of work that was done. This is NETHIPS, which is the national network in Sierra Leone, actually turned the Community Treatment Observatory data into an advocacy win. They were able to secure a commitment from the government to develop a DSD policy, which links with what Anna was just speaking about from Sierra Leone. The policy was signed by the government and the National AIDS Secretariat in 2019. And as a next step, NETHIPS will now work closely with key partners to mobilize the resources needed to implement the DSD policy. This is a snapshot of our key publications on community-led monitoring. And then I wanted to end on this last slide, which is really thinking about the future and it being community-led, right? I've spoken before about the fact that we find ourselves challenged to help people stay on treatment and in care, especially in these COVID-19 times, as resources are now splintered and, in a sense, cannibalized by other competing needs. And we anticipate losing gains as a sector in HIV over the next few years. We have Peter Sands and the Global Fund talking about the need to urgently find, billions of dollars to protect the gains that we have made over the last 20 years for TB and HIV and malaria. And I want to say that a major part of the answer is really community-based healthcare. The answer is right before us. The future is community-led. I really think that the community should be the unit of focus now, because we've learned it from pop art to Ebola to now coronavirus. Communities are innovating. They're not waiting to be invited to the table or to be included in studies, but instead they are the ones that are leading the way. Community-based and community-led healthcare delivery needs to be prioritized now. Thank you very much.